We're now going to move on to discuss some cases that I hope are going to be interesting to you. They certainly are challenging cases to manage from my perspective. So let's go ahead with the next slide. And we can have the following slide, please. These are my disclosures. Next slide, please. So our first case will focus on an individual with chronic kidney disease. And let's go to the case. So this is a 73-year-old man who presents with 2 days of sore throat, rhinorrhea or runny nose, a low-grade fever of about 38 degrees centigrade, no cough or dyspnea. Now, he's had 3 immunizations with the original mRNA COVID-19 vaccine and received a booster with the bivalent vaccine 4 months ago. But with his symptoms, he tested at home and through a rapid antigen test found himself to be positive for SARS-CoV-2. His past medical history is somewhat complicated. He has stage 3 chronic kidney disease with an estimated glomerular filtration rate of about 45 milliliters per minute. He also has hypertension and type 2 diabetes. And for these conditions, he is taking lisinopril, metoprolol, and metformin. Can we have the next slide, please? So let me ask our 2 faculty presenters, what treatment would you recommend for this patient? And maybe we can start with, would you recommend treatment for this patient? Let's start with that question. And let me start with you, Katja.
So this is a really interesting case. So I know that the patient is older, has comorbidities. So he was vaccinated, he tested positive again, and he clearly belongs to the risk of the category of patients that are at risk of evolving to a severe COVID-19. And based on the NIH, CDC, and WHO guidelines, treatment guidelines, it would qualify for treatment. Now, if we look at the current recommendation, so this is a patient that is not hospitalized, that does not need supplemental oxygen. It would qualify for treatment with an antiviral. We have also seen earlier that at some time point it was possible to use monoclonal antibodies, but with the latest emerging SARS-CoV-2 variant, the issue of the currently available monoclonal antibodies is they don't retain activity. So basically we are down to 3 options. So the preferred option are the antiviral SARS-CoV-2 nirmatrelvir boosted with ritonavir or remdesivir. As we have seen, so nirmatrelvir can be given orally, so present the advantage of the patient to receive the treatment and do it from home. Remdesivir implies to go to the clinic for 3 infusion, which can be a bit more challenging. And then molnupiravir, which is a second choice treatment. The HENELD.
Let's stop there for a second. Let me get Jeremiah's thoughts on would you recommend treatment, and then we can talk a bit about what treatment you might recommend.
Mm-hmm.
Yeah, for me it would be the fact that they are high risk. And, I've seen a lot of these renal failure patients not do so well. So unfortunately for us, it depends on the day of the week that we get this referral. If I can get this patient in for an infusion, given their kidney status, when was that last one drawn? That's sometimes a question for me. They do have some kidney dysfunction, and if it was recent, then I can believe that. But I would err on the side of getting this person in for an infusion. just because of the age and the renal function would worry me. But I get a lot from talking to folks, and the other thing is you could do is start antiviral oral medication, and I give them my number. I said, call me back if you feel like you're getting worse, but with clear directions on when to go to the hospital, when to call 911.
So you would favor intravenous remdesivir over oral nirmatrelvir ritonavir?
Well, I guess that's in the context of when their last GFR was taken.
Well,
if it was recent, then I would consider. I'm sorry.
Well, let's assume it was either recent or that you can confirm that, because getting a creatinine is pretty straightforward. So
then I look at renal dosed Paxlovid.
Katja, what would be the considerations here about dosing for this person?
Yeah. So the estimated eGFR is 45. So for this eGFR, the recommendation would be to halve the dose of nirmatrelvir. So instead of 300 milligram, you give 150 milligram. Together with ritonavir, you can use the full dose of ritonavir, so 100 milligram, and you give both drugs twice daily. So the only difference is that you take one pill of nirmatrelvir instead of two. If you have an eGFR, so a moderate renal impairment.
Right. So how do you instruct the patient? Because I think that's an important point. The dispensing of the drug is still going to be the same packet, right? They're still going to get 2 nirmatrelvir and 1 ritonavir in each of those bubble packs.
You should instruct them to remove actually half of the blister. That's the easiest, is to avoid any mistakes anyway.
And is there any role?
That's one of the most important things, because they don't tell the patients. I've had them early on. I learned this, because patients called me and said, you said to take this many pink pills, this many white pills, but they got all of these pills. So that's how I learned very early that we need to tell these patients, because the pharmacy will dispense all of them.
Mm-hmm.
Yeah, I think that's the trick. I'm sorry, go ahead, Katja.
Yeah, I think this is you mentioned, Jeremiah, that you were actually, the pharmacists were a biggest part of that they were necessary. And I think in this particular situation, the pharmacist could intervene early on and actually basically prepare the correct amount of pill to avoid any mistakes.
Yeah, that's if the prescription hopefully would direct people on how to dispense, but whether they can, whether at a local pharmacy that would happen or not, I think is an open question. That's an important point. What about inhaled steroids? Do they play any role in treating somebody like this? There's some data that suggests inhaled steroids can be beneficial, not oral steroids, but inhaled steroids.
Well, not sure. Based on the guidelines again, the steroids would, at least the systemic one is when you need supplemental oxygen when the patient are hospitalized. For inhaled steroids, I'm not sure about whether or not they would be preferred over a antiviral. I don't know, based on your experience, perhaps.
Yeah, so I think certainly not preferred over an antiretroviral. There are some data that inhaled budesonide can be helpful, but those studies were done really before nirmatrelvir ritonavir was available, and I think at this point I would probably not recommend the adjunctive use of inhaled steroids in addition to antiviral therapy. Any other considerations in treating this patient? How would you monitor them during their outpatient treatment?
So
me,
maybe an important consideration
I'm sorry.
is, I'm sorry, looking at because I think this is always a bit the decisional factor on whether or not to prescribe nirmatrelvir-ritonavir is actually the risk of drug-drug interaction. And if I look at the co-medication that the patient is on, he receives lisinopril, which does not interact. It's eliminated renally, but there is no interaction via CYP3A4. Metoprolol is metabolized by CYP2D6, and it's important to mention that, I mean, people see cytochrome and they think, okay, interaction. I think the interaction with the cytochrome is via CYP3A4 mainly. You have to know that ritonavir, when used as a booster, as a low dose 100 milligram, is a weak inhibitor of CYP2D6, so we don't worry about having a clinically relevant interaction with metoprolol. And for metformin is eliminated renally, so again, no interaction. So I think I would personally feel comfortable to prescribe nirmatrelvir-ritonavir, considering the co-medication that the patient is on. As I showed before, there is, I mean, really the risk of DDI really can influence the choice of the antiviral treatment. And we have seen that in this Italian study that elderly people, because they receive more co-medication and because they have a higher risk of drug-drug interaction, tended to be more often given molnupiravir, because we know that it doesn't have any drug-drug interaction. But based on the medication that the patient is taking, I would not worry very much. And perhaps, I think it's always important to mention what are the potential adverse effects of, Paxlovid, so people are not surprised. So there is, can be this dysgeusia, so it's the taste is a bit altered. So, but this is nothing really critical. So it's important that people are informed and don't stop taking the medication because they see something different. It would be really could have potential deleterious effect of not completing the treatment, as they would not be able to clear the virus. So it's important really to inform people. It's important to tell them not to take any other, even herbals or any other substances without, informing their physician, because there is, even drugs that we would not think of much of can potentially interact. So it's very important to not take any additional drug without, asking the physician.
Jeremiah, thoughts about how you would monitor this patient?
Yep. The only other things I would say is, I provide them my callback number. I said if things, are getting worse, and also let them know about the side effects we talked about, and also tell them, about 5% of patients can get nausea and diarrhea. Some patients already have that, but just something for them to know that they can watch out for. And then going back to ordering with the renal dosing, I always, in our electronic medical record, you can send or put on a note to the pharmacist. And when it is a renal dose, I put that in there, just one last check, that maybe they can see so they can pass it on to the patient, so that I'm telling the patient the amount of pills, colored pills to take, and hopefully that can be reinforced by the pharmacist.
Mm-hmm.
Yeah, that's great advice. Well, that was a really terrific discussion of this case. Let's go on to our next case. So this is a case of a recipient of a solid organ transplant, and we can go on to the next slide. So this is a 39-year-old woman with a history of systemic lupus complicated by end-stage renal disease. She was fortunate to have received a living-related donor kidney transplant 3 years ago, and after a period of mild rejection, has now become stable on low-dose methylprednisolone, mycophenolate, and tacrolimus. She's experienced 3 days of low-grade fevers, malaise, and nasal congestion, has no respiratory complaints, and has a O2 monitor at home, and she has an O2 sat of 98% on room air. She's received 4 immunizations with the original mRNA vaccine, and in accordance with current CDC guidelines, had received 2 boosters with the bivalent vaccine, one when it first came out and one more recently after the recommendation for a second bivalent booster for such patients came out. But her transition has been monitoring her spike antibody titer, but he had told her that her titers were low. A year ago, when it was still available, she received an infusion of tixagevimab plus silgivimab, which many people also know as Evusheld. But of course, that's been some time in the past. So let's go to the next slide. So let's start with you, Jeremiah. Would you recommend treatment for this patient? And if so, what treatment would you recommend?
So of course, the Tacro would react with Paxlovid. And it's been our practice here to not adjust that. Maybe need to reconsider after today's talk, but we've not messed with the tacrolimus. So this patient, I would offer an IV remdesivir course 2. Symptomatically, it all depends if they can get to the clinic. If not, I would order Molnu and see how they do. I've had a lot of patients do just fine. We look at organ or solid organ transplants. We've had our own internal, workflow of how we work these. If it's solid organ, if it's not lung, we've done Molnu, and then if they get worse or they're not improving after a few days, we'll talk about an infusion. If it's lung, we will offer an infusion right away.
How long do you wait, and what would the parameters be? Because obviously, with all these interventions, the sooner you intervene, the better off you are.
Right. So we get them on orals as soon as possible, and then and the reason being is that we have that window for the IV remdesivir being longer. We'll even go out to day 10 with these folks. So, and there's always some gray area, and it really depends on their symptoms, because we don't know all the time what their response was to vaccines. So I tell them to feel free to call me, even if it's over the weekend, and we can have a discussion whether they need to go to the emergency department or if we can wait till Monday to get them set up for an infusion.
Yeah, I think that's really helpful to have that sort of immediate option of molnupiravir while you're arranging the IV remdesivir. Katja, any different thoughts from you about how you would approach this patient?
Well, this is a very nice example, and I think it's a situation that has been discussed a lot. And if you ask the question to 10 different person on how they would, whether or not they would give Paxlovid, I think you would have about half and half. I think clearly there is an interaction, so it's clearly not an easy interaction to manage. So you have to take this into account. Now, why did we have so much discussion around whether or not to treat? Because there has also been some time points last year where, for instance, remdesivir was maybe not available. There was, you didn't have this option everywhere, or, it was not available for for a certain amount of time. And so you had to treat this patient knowing that they are at risk. This is a population at risk of evolving to severe COVID-19. And so we had the discussion, with people, prescribers who were, experienced, so were like prescribers that were following up transplant patients, were used to, manage drug-drug interaction, and generally they felt comfortable. I presented the study that was done by the Canadians. So people have done it. We know that what is important, the message, if you want to treat with nirmatrelvir ritonavir, you have to pause tacrolimus. So usually you start the nirmatrelvir ritonavir about 24 hours after the last dose of tacrolimus, and then you treat, and then you have to do therapeutic drug monitoring. And if you do like this, in principle, you can, manage the interaction, but it requires, a close monitoring. And the idea of thinking, well, a 5-day, treatment course will not cause an interaction, this is wrong. And I repeat it because if you look at the literature, there is a lot of cases of, patients that were maintained on tacrolimus, probably because, people thought, well, it's not going to be problematic, only 5 days. And they ended having very high level of tacrolimus, and it doesn't take many days to go up. It goes up very fast because inhibition starts right away, and it's really high level. I mean, values of 60 milligram per liter, when normally, you want to be much, much lower. So I think it's very important to be aware of this. And I know that, in my country, nirmatrelvir ritonavir came at a later time. So, prescriber had to, they had to treat, and they used either monoclonal antibodies, I'm referring to last year, or remdesivir, because, they knew it was possible to treat. There was no issue of drug-drug interaction. We did not have molnupiravir, for instance, in Switzerland. So the question didn't come. But I know that in other places, people have also used molnupiravir last year when they had this patient that needed treatment. So yeah,
it's
a difficult one.
For people without complicated pharmacology considerations, nirmatrelvir ritonavir has generally been preferred over molnupiravir because of its greater efficacy in the clinical trials. Although there was recently a VA retrospective study that was published from the Veterans Affairs here in the United States that suggested there might be a really substantial benefit from molnupiravir. Of course, that's not a randomized clinical trial, and it always needs to be looked at very carefully, but may be another option, especially if there are delays or challenges in administering intravenous remdesivir. Any different considerations with respect to inhaled steroids in this person? I suppose it's the same issues as before, right? Perhaps with the additional concern they're already getting methylprednisolone, and you don't want to tinker with their overall net state of immunosuppression too much. What about, since we're talking about the steroids and inhaled steroids, Katja, you mentioned that the brief duration of nirmatrelvir ritonavir in most circumstances shouldn't be a real consideration. We know that with ritonavir or cobicistat boosting of HIV therapy, there are certain corticosteroids that can lead to very prolonged persistence. Is that a concern at all here, or not so much?
So So we know from the literature that inhaled corticosteroid, if we look at the case of Cushing syndrome in HIV patients that were on boosting with ritonavir, it really takes, couple of weeks and months of concurrent administration. So now, when we mention corticosteroid, you have to think about I'm thinking about triamcinolone. This is a corticosteroid for which we have a lot of Cushing syndrome reported in the literature, because again, people think, well, you inject it. It's not gonna be a problem of drug-drug interaction, and this is a wrong belief. And it's the same for the ointment. If you actually have a big surface and you put a corticosteroid and ritonavir, you can have Cushing syndrome. So The idea that the drugs that are not administered orally, topically, and cannot cause drug-drug interaction is not always correct. So I just mentioned, that triamcinolone would actually be a problem with neonatal ritonavir because you inject it and it's a corticosteroid that stay on board for a long time. And so there has the literature report cases of Cushing syndrome only with one injection. But I would assume again that given the fact that nirmatrelvir ritonavir is given only 5 days, so still the risk would be low.
And Jeremiah, you mentioned in part of your discussion about how you scheduled the patients for remdesivir infusion at the end of the day after other potentially vulnerable patients had gone home. Can you say a few additional words about what are some of the infection control issues around providing infusion therapy for people with COVID-19?
Yeah, well, so we do it at the end of the day, and they come in with a mask on. All the other patients are out of there by then, and the staff is wearing PPE, protective gear, and then that room is closed off, and we have HEPA filters in there. Those are the big things, and then those rooms are special cleaned at the end of the day, in between, before the next business day.